Dr. McLaughlin is a professor of radiation oncology at the University of Michigan and director of radiation oncology at the Providence Center, I guess it is, at the University of Michigan. His main interest is research and development of new technologies in radiation oncology, and he has introduced MRI into the planning process of radiation oncology, which is a big step forward. I happened to hear about him just recently because, I go online and I go to websites or YouTube channels like, the one I saw videos on was Grand Round to Neurology, which there are a lot of excellent presentations there, mostly directed to clinicians. And the one I saw was his discussion about minimizing the use of ADT and personalizing the approach to the patient, which I thought was a very unique approach. And that's one of the reasons I was excited about having him present to us. And with having said all that, I think that's enough. And I will turn it over then to Dr. McLaughlin. Go ahead, Dr. McLaughlin, sir.
Great. I'm going to try to get my screen on here and make sure you can hear me. Everyone able to hear me?
Yep, loud and clear.
A little kind of a funny buzz now and then. I'm not sure what that is, but you can see the screen okay. We're good to go?
Yep, it looks like you got full screen and everything should be good.
Okay, great. Can I hide? Well, we'll just leave that. I think there's just some places that it's over a little. Oh, perfect. Okay. So I really appreciate the opportunity. I was very impressed. We had some back and forth with Ethan about this, what I might talk about. He even gave me some questions for tonight. I'm going to give what I think is a little bit more of a workshop talk. Very, very practical, very detailed. It's a little over an hour, the talk, so prepare yourself. But it's not a sit back and listen. I want you to really attend to this and see the process. The process I described, I think, would be very useful to anyone trying to sort out their options very carefully. And it's a unique approach, but I think it'll be very valuable to many of you. And I'll talk about what I would say is the modern definition of successful cancer treatment, which is cure with quality of life. This would be cure at any cost, right? 30 years ago, late 80s, men were willing to do a great deal to achieve cure and give up a lot of quality of life. Now it's not so. So I'm going to talk about approaches to individualize patient efficacy. That is really the modern challenge. So we begin with probably the most shocking notion any of us can ever have is the science of n equals 1. N is the number of participants in a study, and the scientific term, but n equals 1 means a study of one person, one individual, and I'm using it poetically, but obviously the fact is, these two sentences are the first things I teach my residents who have never seen a patient like this before, and you will never see a patient like this again. Are you experienced? So I hope to convince you that you have never seen a patient like this before and you will never see a patient like this again is an absolute truth of science. And actually the modern oncology method is sorting through. But let's go to a bigger picture, what everyone would look for in a study. You'd like to read a study and say there were 35,000 participants in the study. Because the more patients on the study, the more valid the conclusion, the bigger the sample. You see, you just get the picture. There are even studies that are designed saying we need 5,000, we need 10,000 patients to answer this question in a legitimate time term. But let's just say on a study of 5,000, 66% of cured by therapy X. The whole conclusion was that treatment is 66% effective. can remember going through residency, this treatment was 80%, this was 60%, this was 40%. So you would memorize a list of effectiveness numbers like that. The new conclusion, though, in the modern era would be 66% of the patients shared a vulnerability to that treatment. And the other 33% had a different disease altogether and should not have been studied with the 66%. So we group patients, we say this is a comparable group, we study them, then you get this kind of result, which is sort of not intuitive, but in reality, this is where we are. The whole mentality has shifted toward the trillion-dollar question, which is instead of putting 500 patients through to find the 60% who respond, can we somehow predict responders or non-responders ahead of time? That would be gold, right? Because right now you're putting 33% through for no reason, a lot of expense, and a lot of toxicity. So we would love to be able to have predictive assays to find out if the treatment is going to work ahead of time. So with prostate cancer, can we predict key outcomes before putting someone through treatment? No, I am not going to talk about chopping up tumors and doing genetic analysis to predict what treatment will work. That's a fantastic realm. My realm is a little bit more mundane, just clinical outcomes, but they're clinical outcomes that matter, and I do think we can predict them. So predicting outcomes, the two critical outcomes, as I've said, are cure and quality of life. Those are the two things every man I see says, I want to be cured, and I'd like to keep as much quality of life as I can. Those are, in fact, I'd say 99% of men come to a consult, and that's what they want. Sizing the cure and quality of life challenge is what I'll be talking about. What is the challenge for you? How hard is it to cure? How difficult will it be to maintain the quality of life? And then defining technical excellence, because that's the other thing I do, is how do we set standards to confirm that someone is actually doing a good job? It's not the best treatment you want, the best proven delivery of that treatment. So there are certain elite groups in the country whose results are 10, 15, 20% better than other groups. And obviously you want to migrate to people who are proving their excellence and their technique. But technique determines outcome more than the treatment chosen. That's a shocking, shocking statement. So you could say, I think seeds are the best. Well, seeds are the best if you find someone who does a great job. High dose rate. I think high dose rate is awesome. Oh no, well, high dose rate in the right hands is awesome. But you have to be able to sort this through and see if the person you're considering is got a proven track record with that. So we get back to the science of N equals 1, then I want to give you a feel for this. Well, here's where I would say good medicine is probably more like golf than bowling. So what do I mean by that? No two holes in golf are the same. Almost an astounding fact of golf, right? No two holes, all the millions of holes on the planet, no two are the same, and yet it's all called golf. We've got a pretty interesting hole here. But then take bowling. Think about bowling. Every lane is the same length, same finish. Now, a great bowler will tell you, oh, this lane is not the same. But get the idea. You actually have doctors who really think like bowling, fit everyone into the same game. This is what we're doing. We have this procedure. This is how we do it. This is how I do it. And they're kind of very ritualistic. Then you have people who are adapting. They're looking at the individual challenge that is a unique challenge. That patient is unique. Now, mixing these two is not a great idea. This is a very tough golf bowling hole. My physicist has told me this is a spare you can make. It would take me like 5,000 balls to make this spare. But the reality is good medicine is like golf and like bowling, because you have to have that ritual bowling approach, and you have to have this adapt to the individual challenge. As I just told you, you're never going to see a patient like this before, and you're never going to see one like it. And you better have your eyes open for those unique features that make this a difficult or an easy case. And interestingly, I could tell you names, I won't name names, but there's one of the 2 out of the top 5 brachytherapists in the universe. One is a ritual bowler style. It's like chop, chop. She goes through her procedure. This is how we do it. Set the legs here, go through this. Every step is just ritual worked out. And kind of, in the end, one size fits all. Everyone fits into her schema. And there is variation, but in reality, her consistency, doing the same thing very carefully, step by step, is good. The other speaker, he says, boy, when I hear her talk, I feel a little nervous because she's so regimented, so organized. And I'm a gestalt guy. I put a couple needles in, see what's happening, and then I take it from there, all by feel. I have to tell you, both of these are they are deeply respected, even revered brachytherapists. I would not hesitate to have either one treat me, but it is remarkable that their own personalities, whatever the great strength of the one personality, organized and ritualized, is perfection, and the great strength of the other, just feel the way, improvise, really truly improvise, and come to the best solution. And yet they both have fantastic proven outcomes. So when I'm teaching residents, they all want competence. They really want to study with the one who does the ritual, and they want to walk away and feel competent. This is a sweatshirt that has been earned by this brilliant U of M resident. I call it Mastery Asterisk. Mastery is, yeah, you know the steps, you've proven to me you can go through the ritual. Asterisk means you know there's going to be exceptions. You have to keep your eyes open. This case before you is going to make it difficult. The simplest thing, I think one of the great asterisk questions I've been asked in the OR is, after a few needles, some prostates just bleed. All the planes are obliterated. I can remember one resident asking one of the great asterisk questions of all time, where is the prostate? So it's like instruments. You got to fly on instruments sometimes, and there's a lot to learn. So my N equals 1, though, for prostate cancer, my approach is, and why I will prove emphatically that there's only you and only you with these individual features and variables that will determine what your best treatment is. These are balls we have to juggle, right? Individual personality is key. Functional anatomy, and I'll go through that in more gory detail than you want. Tumor anatomy, finally dynamic anatomy. And so we'll just go through this one by one and see how these come in. Individual personality, if any of you got to listen to the website, the musical on there, makes it very clear that personality is a major player in these decisions. About it, we spend all our lives trying to get science, good scientific data, and evidence, try to do evidence-based medicine, and then someone walks in, like a man 2 weeks ago, said, "Doctor, I don't know why anyone in their right mind would choose anything but surgery." Now you can fill in the blank, but who taught him that? This is not even a medical person, no medical background, but in his mind, in his heart of hearts, in his personality, the only thing that makes sense is surgery. And you could also say there's someone else who comes in and says, "I can't believe anyone would ever do surgery," right? They can have these, but these are personality. These are obviously personality, not data-driven decisions. Your gut. People trust their gut. Sometimes they trust their gut perhaps a little too much. But I'm going to come at this question a little bit differently. This is classical medical decision making. So this is a triangle, and to the left is a small end of the triangle. Cure is of limited value, and this is to the right. Cure is of infinite value. So this should look familiar, right? Prostate cancer to the left is low risk cancer. You might not even treat it. So you have sleepless nights for 2 weeks, and then the doctor tells you this is a cancer that will never live up to the word cancer. Go home and watch it. You have no idea how shocking that was 20 years ago. That was, many patients could almost get up and walk out at that point and feel that you're certifiably crazy. On the other hand, to the right, cure is of infinite value. There are very deadly prostate cancers that have to be treated very, very aggressively, or you can die of them. So there still is a death rate, there still is a threat. And for those, cure is of infinite value. Quality of life is the other concern. As I said, people patients say, I want cure, I want quality of life. And on one end of the triangle, quality of life is of infinite value. This is what I value. This is what I'm trying to protect. At the other end, quality of life is of limited value. Sometimes in life, quality of life is pitched for a greater cause. So the usual way, if you look at all of medical history, how decisions have been made, those two triangles interlock and they affect each other. So over to the right side, this is the big end of cure. Cure is of infinite value. And at that point, you might say, just cure this, my life is threatened. Quality of life might be of limited value. As I said, 30 years ago, men would be told, you will never have an erection again. You may have leaking urine. And they'd say, sign me up, let's get this done. You would sacrifice quality of life freely because, right, we were fighting a war on cancer, and in war there are casualties. That was just part of it, right? It was not even, you can imagine not having casualties, but you accepted a lot because the stakes were high. On the other hand, cure is of limited value. This is classic, someone with a low-grade cancer. Then you find quality of life. Wait a minute, why should I treat this? I might lose my erection. I might lose my continence. I might lose a lot. And all I've gained is what, a number on the page. And so this is sort of the classic way these two interact. But I have to tell you, the modern world is not configured this way. Individuals, it's that individual personality as a way of sizing these two. You will not go into a room now and say, yes, we're going to cure this, but you're going to be incontinent and you're going to lose your erections and whatever it is that you don't want, you're just going to have to accept it. That's the price you're going to have to pay. So if we look at this, what do I mean? Well, I could see the patient with almost the same disease. 4 patients here. Upper left, cure is quality of life. Cure is quality of life. Why do we have to stop hormones after 2 years? Why? Well, gained weight, you're not doing anything, you're depressed, have no sex life, your penis is shrinking, and everyone finds you're kind of irritable and nasty. That's a lot of good reasons, but to this person, they don't care. They'll take it forever as long as it increases the cure rate. I had a patient tell me, literally, why do we have to stop radiation after 8 weeks? Just keep going until my rectum falls out. And so that's a person who has a personality like that that big blue triangle. I don't care what you have to do, cure this. I don't care what I have to do. To the right, have a big quality of life triangle. I don't mind being aggressive with radiation, but I refuse to take Lupron. I refuse to take hormone therapy because I don't want to lose my manhood. I'm an athlete. I'm still sexually active. I still feel great. People tell me I'm 10 years younger than my age. I hit the gym 5 days a week. I feel great, alive. I am not going to give all that up for some theoretical advantage. Left lower. Just get rid of it. Hit me with your best shot. I don't really care about erections, but I don't think I could live with incontinence. This is a very common one. For some men, it is unfathomable for them to be walking around in urine. Other men, it's actually not that big a deal. It's kind of shocking, you might say, but it gets normalized. All these things you lose with life get normalized. Finally, it is not worth it to me to go through all this, doctor. In the end, I put myself in God's hands. I don't have any symptoms at all from this little blue triangle, little gold triangle, big circular orb of eternal peace, child of God, however you want to put it. But these are personalities that each collide with the cancer and have a completely different way of sizing cure and quality of life. So take out a piece of paper sometime and draw the cure and quality of life triangle as you see it, how you would fit them together. Because I guarantee you this is going to be in the mix in your decision. And I will try to see how you remember that. So that's individual personality. I hope I've convinced you that's a major factor. I also would tell you that the role of personality is not something academicians like me have studied or been very hard to study, and that we have to study it because it's a major factor. Some patients come in and I could talk to them, I'm blue in the face and give them surgery. They could go see the surgeon, he could talk to them, blue in the face and crash radiation. They want radiation. but it's their gut, their personality that's driving them there. And we need to understand this, because when it works, it's great, but when it misfires, it's not good. So then functional anatomy, I sent you an image of this. This is, I think, suitable for framing. It took me almost 15 years to figure this out, but this is a picture of the prostate. Prostate is this pink heart-shaped structure here, and look at all this function streaming through it, all kinds of sexual function, rectal function, bladder function, and it's a masterpiece of physiology, astounding in reality. But I would say because of all this, it's the premier challenge in radiation oncology, why I find it fascinating. It's a lot like that operation game used to play where you'd reach in with a tweezer and try to take out the tumor and not take out a whole bunch of important things. So this will never get a better challenge. But there's two. The other reason I put this on is that you can see the variation, the vexing variations of these different structures. And so if you look, you can see that some people have a long GU diaphragm. We'll explain that. Other people have nerves that are in a bundle. Others have a plexus. Others, the vessels that supply erections don't come anywhere near the prostate, and some those vessels are up right in and under the prostate. So the challenge varies, but the variations make it very confusing. What am I looking at? How could this be so different? And, so that's a lot of Prostadoodle is an atlas I created to deal with these, log all these variants. Free atlas, I posted it 20 years ago. We still get over 100 hits on this. I see it's an antiquated device, but it's very, very useful. So how do we use the functional anatomy? Simplest, use three things. I'll just emphasize three things. Bladder, neck can predict whether you'll need a catheter. External sphincter can predict whether you'll be incontinent after surgery. And the nerve bundle configuration can predict your sexual function after surgery. May also predict some things with radiation. The bladder neck variation. Bladder neck refers to this. This yellow is your bladder, blue is your prostate. The urine runs right through the prostate, through this urethra. And bladder neck is this opening, this funnel here, where the bladder opens into the prostate. There's a little valve there. That valve opens. Urine passes through. Outer sphincter has to open as well. So very coordinated, complicated thing, just to urinate. So the bladder neck region, though, now you're going to look at it from the side because I want to point out something. But this is the bladder. That's the urine. And then you see this nice tight funnel here. Then the next one, you see the prostate has enlarged. It's sort of opened up the funnel. It's not tight anymore. It's actually pushed open. And here you have a prostate, barnacle bill, kind of gnarly looking prostate, and it's pushing right up into the bladder proper. It's bulging right into your bladder. Finally, you have an asymmetric expansion called the median lobe that's like a funny finger or lobe sticking up, and this actually grows over the other, and this grows over the urethra, and the harder you get a ball valve effect. You're mechanical engineers, the harder you push down, the more that valve pushes down and shuts off. So class one, nice funnel. This is a small prostate, young man. Class two, prostate getting bigger, and it's sort of growing up into the bladder neck. Class three, that barnacle bill pushing right into the bladder. And finally, this lobe case. So these are staggering differences, right? But the most staggering thing of all is that structure does not always predict function. Jim Monty, who worked on me on Prostadoodle and was like the greatest urology resource I could have. Any urologist here would know him. He's a very famous urologist from Michigan. But we would exchange hundreds of notes over a few years as I was putting together Prostadoodle. And one of the things, I'll never forget what he said. He said, Bill, you have to realize something. Women have all these problems. They don't have a prostate. So you think, oh, massively enlarged may have no obstruction, right? You think, oh, it's big, your prostate's getting big, it's going to block off. No, I've had guys with 140 cc prostates, no trouble urinating. Small glands may have profound obstruction. Getting a little music there. And then median lobe patient may have no obstruction at all. So, not sure. Okay. So here's the man. You can see the median lobe we just talked about. His father had seeds. His brother had seeds. He said, I have to have seeds. I said, you can't even pee. If we put seeds in there, you're going to have a catheter for months. So what we did ended up having a urologist take the median lobe out. So you see to the right, median lobe has been removed. And of course, he has seeds now. But what's interesting is the urologist I worked with for years was willing to do the so-called golf TUR. You just open the bladder neck, left everything intact. The usual TUR, where they resect and open things up, they bowl out the whole prostate. You very little tissue. I couldn't do an implant if you did this the way they used to do it. And you could also have incontinence with that. So this is a very minimalist procedure, but it did the job. He had seeds, great. This is the other use, though. This is someone who had one of those big bowl-outs years ago, but now as time goes by, they start growing back up that. He still has a nice TUR defect, but he's got plenty of meat he wants to do. So bladder neck function testing, what you have to do is one of two things. One is post-void residual. You empty your bladder, make sure it's empty all the way. Problem with that is it might have taken you 10 minutes to empty it, and that's not good. The real thing you have to do is measure flow rate. If you have a flow rate above X, you will not obstruct your catheters. Very handy, very important. And external sphincter variation. This is our next step. This is the other end of our urination. This is the blue prostate. This is the sphincter everyone lives on. This is the main sphincter that gives you continence. Because if you take the prostate out and connect the bladder to the sphincter, that sphincter is doing it all for you. Right? With the bladder and the prostate in, you've got a couple valves holding that in, because everything falls to that. So if you look, one of the most famous surgical papers of all time, from 2002, Coakley, Journal of Urology, looked at this distance. Sorry, let's present the screen. Looked at this distance. This is the bottom of the prostate. Again, you see the heart-shaped prostate. The bottom of the prostate is the apex. Below that is the sphincter. It goes from here to here. If he measured that distance, and that distance was over 1.5 centimeters, almost no man had incontinence surgery. So you got that guy who's petrified. One fear of all fears is you will have urine leak. Well, if he's got an adequate sphincter, external sphincter of surgery, and it's almost unheard of, you have a problem. So, but look at the staggering variation in this. This is prostate up here. The red is the sphincter. This is 2.7 centimeters in length. This is another patient in half centimeter. So you can imagine what happens, right? If you're a surgeon and you're aggressively trying to take the whole prostate out, you could easily take the whole sphincter, the whole valve that controls your urine out. So, so what do we know? Well, we know that if that's under 0.5 centimeter, the actual incontinence rate approaches 20%. So it's not 50 or 80 or 100%, it's 20%. 20%. And that guy who is terrified of incontinence, again, over a certain thing, your goal. So nerve variation, again, how can we use this information? Well, this is where, these are the nerves that Patrick Walsh described for nerve sparing. See this nice bundle, posterior lateral, classic nerve bundle. See those little dots and this nice shroud around it? That's the neurovascular bundle, famous. Here it is in this patient. You can see it a mile away, posterior and lateral. Problem? Only 55% of men have that bundle. 40% have what's called a plexus. And see, you cannot see a bundle in these patients. You look here and here, there's no bundle. You see these dots along the side, this smear of nerves all over the prostate, and this is what I would call plexus. 40% of men have that. 5% of men have nothing we can see, even though we know they have nerves that are getting there somewhere. So again, we can look at this ahead of time. Now, I have to say, big challenge in trying to score this. This is still unsettled, not settled law. You can have different people look at the same scan come up with different opinions about whether the bundle is there. There's no good scoring system yet, but we're working on it right now. I'm going to have 2 residents work very, very hard on this next year. So you cannot score all patients, but I can tell you one thing. If you have that classic nerve bundle that Patrick Walsh said should be there, it's going to be about 50% of the time, and you will have a very good sexual preservation with nerve sparing. If you don't have it, this is kind of the schema we're going to use. I don't want to go into too much detail, but you can recognize these different patterns well enough to score this. So how does this work? If you have that nerve bundle, then 60 to 70% of the time you'll have preservation with nerve sparing. If there's no bundle and they do classic Walsh prostatectomy nerve sparing, you'll only have 15% preservation. If the plexus is present, smeared over the side, there's a new procedure in the last few years called the veil of Aphrodite. Lift the veil of Aphrodite. This is one of the great names of all time for surgical procedure. What are they doing? Well, instead of taking the corner off, they're literally onion peeling the outer fascia. All those nerves are resting in. They literally peel the fascia off the prostate with the nerves. They stay in the body. The prostate goes. Problem is, it's a very high risk of positive margin because there's tumor right under that. Right under that layer is the peripheral zone where tumors form. So, again, I think in this case, I would say maybe the triangle for cure and the triangle for quality of life got mixed up. Surgeons are kind of compromising cure to spare those nerves. I don't think you should ever do that. I don't think this is a great thing unless you know there's no tumor in there inside. We'll get to that. Finally, the bottom of the prostate, the apex, is the greatest cure and quality of life challenge. Everything converges at that bottom. You saw the sphincter earlier. The apex is pure peripheral zone, which means tumor generating tissue. Nerves terminate there, come down to the apex, and then they just disappear into this final fibrous, they call it cauda equina, microscopic horse's tail. Just can't even see it. Surgeons can't even see it, but suddenly these nerves become these microfibers, and we think those are very, very vulnerable. And remember the Peter heater approach to cryo. So when they used to do cryo and they did it well and they froze the whole prostate, the incontinence rate was 40%. It's ridiculously high. Maybe not that high, but it was extremely high. Why? Because they were freezing the apex, they were freezing that external sphincter. So what they decided was, we will put some warm water through a catheter, run it in while we do the cryo. Apex will not get super cold, and therefore we will spare the sphincter. So what happened? Well, the sphincter continence rate went up. The failure rate went up because they were sparing those tissues of freezing. And this is, again, I think a mix-up, right? We all have to keep our triangles clear for cure and quality of life. We can't say, oh, I don't want to ruin that sphincter at the expense of tumor recurrence. This was a method for a time. So, prostate, just to be clear, this is the center part, very different tissue than the outer rind. Outer rind, 85% of tumors form in that. The middle part is what overgrows as you get older, and that causes age. But here's what I mean by the apex. See how big the transition zone is? In this patient, at least 65% of the prostate is transition zone, which rarely has tumor. And then peripheral zone is that rind. But look at the bottom, the apex, right there. All it is peripheral zone. All it is tumor. And anyone will tell you we are always getting beat at the apex. There's all this functional anatomy, there's all this tumor. So what I think has changed in an interesting way is, from some of my work and certainly Patrick Walsh's work, is a shift from trying to avoid really bad toxicity all the way to preserving function. So what we would like is, a year after treatment, we would like men to walk away with full continence, full sexual function, no rectal complications, really almost the exact opposite of the 1980s, where you give up all this function for the sake of cure. We want full preservation without medication. And, you know, I've crossed out the severe or irreversible complications, and really I shouldn't, because what we found, one of the most famous papers by Merrick, one of the real legendary. If you want to read about brachytherapy, read Merrick. Everything by Merrick is great. But he did an amazing study years ago. They had severe complications. They found out if we can keep dose under X, those things won't happen. Well, Merrick, being Merrick, went back and had 30,000 patients treated, and he looked at all the severe complications. And what he found is deeply troubling. What he found is that most people that had those terrible complications had a safe dose, lower than the red line dose we described before. And many patients had 4 to 5 times the safe dose, the red line dose, and had nothing. No ulcer, no rectal bleeding, nothing. So they could take 5 times the dose, not have complications. And a group of men, and it's small, 1 out of 300, but gosh, we know they're there, and it's sort of terrifying. They have a vulnerability complication. You can do a perfect implant, perfect treatment, and they can develop a devastating, life-altering, terrible complication. So a lot of our research now, a lot of my research now is trying to come up with a way to tell who these men are who are vulnerable to disaster. We will figure it out. It's just not straightforward. So if we just go through my claim to fame, I guess, vessel sparing radiation, all we did is map out the erector set below the prostate, and then we were able to treat the prostate and limit dose to these structures. Now, people that do CAT scan planning are constantly including these structures because they overestimate the prostate. They're afraid to miss the prostate, therefore they overestimate and end up set. So interesting things here, though. 90% were able to be sexually active at 5 years. 70% had decent erections by this IIEF score. I won't go into that, but that's 16. Any man over 70 would take a 16 for their erection scale. No difference at 5 years for combination for ADP patients. So these are men with bad cancers. They got C plus beam. And they also had 90% preservation of sexual function. If you read anything about aggressive treatment, you'll see, oh yeah, aggressive treatments cure anything, but there's this big price to pay. All these guys end up with erection trouble or major complications. This proved beyond any shadow of a doubt that those structures and not the treatment determines the complications. So for me, that's the exciting part. The other exciting part is we kept the triangles clear. Okay, I did not ever limit dose to the prostate to spare these vessels. Our first priority was always full dose to the prostate and tumor, and spare what we could. We still got a spectacular result, but I don't have to lose sleep at night. Sacrifice cure for quality of life. Beyond vessel sparing, well, this is kind of almost like a Saturday Night Live skit. I have to tell you, I would ask these guys after they filled out their surveys, I'd always quiz them, and they'd say, "Can you have erections?" Yes. Can you satisfy your partner? Yes. You have a climax? Yes. And the next moment, some men would get sad to the point of tears. And they'd say, "I'm ruined, doctor. I am ruined," in tears. Why? They didn't ejaculate when they climaxed. They didn't realize that this treatment is going to take away their ejaculate. Now, surgery takes away your ejaculate, but it's all expectation, right? No. Suddenly, I am not a man anymore if I don't ejaculate. Right? It's sort of, I mean, I don't know. I can say, no muss, no fuss. Right? My sympathy was, I'm checking off my emergency checklist. You got erections, you satisfy your partner, you have a climax, feels great. I'm not feeling, at least at first, years, but I sure was hearing the anger in some men. Some men said, "If you had told me this, I would never have done it. I'd rather die than lose my ejaculate. I'm impotent." So for them, the whole idea of sex the whole idea of climax and sort of the erupting like Vesuvius is all tied together. It's a critical part of it. And even though at first I said, you know, gosh, great expectations, right? We all have great expectations of the pill, but actually, as I thought about it, looked at it, and started looking at the physiology, there is a pathway. I don't want to go into great detail to tell you it works. I have a 73-year-old man right now who will tell you he has ejaculate every time he has sex, has minimal to no ED. He's completely thrilled with his outcome. I have younger men who were very sexually active, and this is sort of critical to them. They also so that's a key piece. It's possible. Again, that gets to that function preservation piece. So let's skip this slide. That's functional anatomy, and that's a lot. Every one of you, though, can get an MRI, look at your bladder neck, look at your external sphincter, look at your nerves, kind of predict a lot, and you might find, wait a minute, I want to be continent. I've got this tiny little external sphincter. I might have to think about it. Tumor is next up. Tumor variation, obviously, is extreme. But I'm going to talk about the TriMap. This is an Excel map app I gave you that lets you put all the tumor information together in one place. If you have any questions about it, you can just email me at UMich. It's very easy to use if you have Excel. Excel comes in Office. But why, in the modern era, did I include digital rectal exam? Why is that still important? Most people, I hate to say it, but most of my residents are no good at exams. Rectal exam. But why is that still important? First, screening has to include PRE, because 10% of lethal prostate cancers do not make PSA. If you don't do an exam, you won't find these are aggressive tumors. They're so aggressive, the cells are so abnormal, they don't make PSA, but you can feel them a mile away. So you have to do that. You have to have PRE. The other piece is prognostically, it's very, very important. A palpable nodule has been correlated in surgical series with very high prostatectomy failure rate. This is any nodule. It goes back to the original great-great-grandfather of surgery who said, if you have a nodule greater than 1.5 centimeter buried in the gland on the surface, if you have anything more than that, the cure rate with surgery 15 years is 0. So these are all surgical papers. Now in 2016, that is confirmed with vengeance. Listed patients treated with radical prostatectomy with positive digital rectal exam findings in the intermediate risk group are prone to PSA recurrence. How prone? This is a graph. Go to the right lower corner. In the top graph here, it's about 90% surgical cure at 8 years if you had no palpable nodule. If you had a nodule, your cure rate is 30% at 8 years, 60%. It's staggering. Just because you have a nodule. But that nodule signifies that the tumor has reached the surface of the gland. And remember, for surgery, if one cell is outside the prostate, you're not going to be cured with surgery. So this is a very critical piece. Make sure, if you go to a consultation and say, the doctor demurely says, I don't want to bother you with digital rectal exam, just say, well, why don't you bother? Because I need to know that information. I need to know. Other doctors thought there was a nodule, but I want to make sure. So it's a big, important piece. How does this TriMap work? Well, it lets you map everything out. And if you have 3 cases on a single day, this patient, all of his tumor is on one side of the gland. You can tell your physicist planning the case, gosh, we've got to go high dose. This whole lobe, that's where the tumor is. The other side really doesn't have tumor. It's a pretty common scenario, but the location within the gland really, really matter, and it's incredibly useful. This is a picture of a prostate tumor. You can see that white rind here. I'm sorry if I'm just so afraid I'm going to move this. But anyway, there's a white rind, and then you see these dark areas in red that are the tumor, so you can literally see where the tumor is. So beyond risk categories, so this is a key thing with tumors. So currently, if you go for guidelines, if you went to almost any cancer center in the country with prostate cancer to get a second opinion, they would tell you, you are X risk. You are low risk, go home, forget about it. You're intermediate risk, you can do anything. You're high risk, go ahead and take aggressive treatment. But they would just have a recipe book based on your risk category and your risk based on PSA, stage, colorectal, and Gleason score. You take those three, assign your risk. A million places you can find this. But I find this kind of woefully inadequate, right? The approach I'm describing, risk is a starting point, but considered insufficient. So I convinced men to wait 6 to 8 weeks after biopsy to obtain an MRI, and then 1 week later we reviewed the MRI. So those 6 weeks waiting avoid a lot of impulsive decisions. So that's the tumor piece. Dynamic anatomy I'm going to go through rather quickly, even though it's the most interesting. I'm going to play this video to show you that what happens when you start putting needles and probes into the prostate. This first part is probe. All we're doing here is this is the prostate. It looks like the prostate is rising from the floor of the ocean. But all we're doing is dropping the probe. It changes the shape of the prostate just by moving the probe around. This is, unfortunately, this just started again, out of the way of this one. But it's going to show you that the very shape of the prostate you can change by how much probe pressure, and that's a dynamic change. What would you rather implant? Prostate that's meshed, not anything from the state or not. And this is needle effects. So we see needles going into the prostate, and the prostate doesn't just sit there and passively let these in. There's this sort of lollipop effect. See, that needle didn't make it to the end. Look at this needle. Almost to the end, very fibrous, pushed 3 times farther, faster, not ever get to the base. This is, watch what happens. You see tensions in the tissue. Watch, this needle looked like it was straight, right? Straight as an arrow, but look, when you drop off, you can see that grabbed tissue, curled tissue into the needle, and all kinds of tension was contained. Look at that. That needle was not straight. It looked straight, it looked great, but it's not straight in the tissue. So all these dynamics have a way of confounding things. We talked about the base error. This is the most basic error that you can make, and that is this is a prostate from the side. The red dots are the seeds. We want them all to be right through the prostate. The base error, the VA error in the New York Times, it scared everyone. They scorned this group and said these are renegade doctors at the VA who did this and what they were doing. Well, the reality is this is a very easy and common error. It may not be as extreme as it was in some of those cases, but when you put a needle into the prostate, it doesn't just pass through to the prostate. You have to go very fast, very hard, and you have to make sure and confirm that it's gone there. So here's the case. When I see cases in review that have been treated and have failed therapy, I can see this, all of this green on the top here, all of this green is out there. And you can see the bottom. And this is the prostate. These are all these seeds. Believe me, I told you before, apex is ground zero. The bottom of the prostate is the last place you want a whole bunch of seeds to pile up. And so what we did years ago, and we're going to reapply, is we created a phantom. This is an 8-pound block, and we have a slow hand. 8-pound block, tissue equivalent, kind of it's used to demonstrate the fact that the needle goes a certain distance and then you get this lollipop effect. Now, if I go faster, I can do a little better. But still, even at the fastest I do, I'm still getting that needle binding. We had, with University of Michigan, we created a pneumatic breed. So you can see over here, you can see the needle, it'll pop. And the interesting thing is that needle is all the way into the depth we want, and this barely quivered. Put another one in, just barely changed. So this would solve everything, right? This would solve everything, but the FDA said it won't work, right? You think this is grease, right? Someone says, we can reason this out. We can tell you it's like a good idea, but it won't work. Instead of science, just test it. All I ask is to test it. And the other thing is it's dangerous. So we have this FDA-approved version to the right where needles never really get where they're supposed to, and even when they look like they do, there's all kinds of tensions, drop off in funny ways. There's FDA disapproved where you can get the needle exactly where you need it. All kinds of get redundant safeties. This is a kind of a painful, absurd thing. But I didn't have all these videos to show them how bad it is. So this is dangerous, right? They said this is dangerous. What's dangerous is when seeds don't get where they're supposed to go, pile up. This is not dangerous. So, and we know in current studies that this is an ongoing problem, and the FDA has to take responsibility because these major technical flaws are seen in current national studies. There's a national study completed last year. 15% of the implants on the study were categorically unacceptable, 15% were poor. So people are doing these and they're not correcting for these dynamic changes. All and they're doing implants are not, that are just not acceptable. So I think FDA, there's a remedy. FDA has to see the problem. Bermuda Triangle is just another vexing thing that, frankly, you can read the paper. I don't want to go too deep in this, but what this turns out to be is kind of a simple thing. This is the rectum. It has a big bend under the prostate. And what fooled everyone is when you put the probe in, the probe straightens out that curve, and everyone thinks they're looking at normal anatomy when they do an ultrasound, they do their implant, and put the seeds in. The seeds are in line with this. Everything looks great, great spacing. Take the probe out, everything snaps back. So it's a big dynamic change. And that took a long time to figure out. You had to go to Toronto, see MRI-based done. Do it. So dynamic prior to therapy, well, I can tell you, if you have a very small gland, rock hard, loaded with high-grade tumor, do better, ready to fire those needles as high as you can. You might even have to make a cage of needles around that prostate just to stop it from flipping on its way. There's tricks for all of these things, but without experience, without facing dynamics, I can tell you, if you very carefully pass the needles into this gland, you will not come close to a good implant. And there are some patients who do not have that bend, so there's no worry at all about that. So that covers dynamic anatomy, and again, this is my thing. I think it's incredible what a difference it's going to make when we start to do full compensation. So that covers the whole functional anatomy thing, except for one thing. There's one missing ball we weren't flipping, and that's the comorbidity ball, which is just the fact that men get prostate cancer late in life, and we're all trying to deal with the fact of seeing a patient and think, well, you had a heart attack 5 years ago, and you got a cancer that's not going to get you anytime soon. How do we think about that heart attack? What do we think of that? How do we factor that in? Do we say, well, you're going to probably die of a heart attack? Well, I have this comorbidity as kind of a gnarly ball because we have no clue how to deal with this. First of all, 20 years ago, 30 years ago, people died of heart attacks left and right. People had acute MIs and they just died. Now, men with cardiac disease, if they have it diagnosed short of a fatal MI and have a cardiologist, people live forever. They get a stent, they get a defibrillator, they get a pacemaker. No one, I don't want to be ridiculous about this, but no one dies of heart disease the way they did before. It was very predictable. If you had a big heart attack, you were going to die within 5 years. And if you had a very mild prostate cancer, then that was decisive. But I can tell you, you might as well get out a Ouija board and try to predict the future as look a patient in the eye and try to write them off. I constantly tell patients, I wish I could write you off. This would make it a lot easier, right? But you don't have anything that's going to get you for this prostate cancer. And therefore, comorbidity that people are trying to introduce and understand. It's just, in my eyes, there yet. So this is my process, which is initial meeting. 6 weeks later, you get an MRI. 1 week later, you review the consultation. You juggle all of these balls at the consultation, tear things apart, look at the functional anatomy, look at the tumor. So these letters, each letter is coded from one of the balls above. Put all of this information together. You generate a plan that I think is individualized, only is going to apply to that particular individual person. But it's a very, very, I think, very elegant way to use this information. Case studies, case 1, 76-year-old man seen in follow-up after chemo and hormone therapy. His initial PSA was pretty high at intermediate risk. And I see him a year out and his PSA is undetectable. The surveys for bladder, bowel, sexual function. He didn't have any bother. He was not sexually active because of the hormone. So I remember literally looking at him and I say, my God, your PSA is less than 0. You are doing great. Then one of the career-defining moments happened. His wife was sitting nearby, quietly taking it all in, almost by cue when I said, my God, you're doing great. She said the following. Doctor, I have to tell you something. My husband is not doing well at all. I've been married to this man for 40 years. Not once in the 40 years has he raised his voice to me. We have not argued about anything. In the last year, he has taken my head off on several occasions in vicious arguments, often about very little. He is mean. I barely recognize him. I cannot believe it's the same man I married. My husband has always been a wonderful, loving man. Whenever he walks through a room and I am there, he says something affectionate or touches me in passing. He never, ever does that. There's an annual golf trip. It is all the men talk about for months before and months after. He's gone on the trip for 40 years. Last year, he decided he did not feel going. So what is the common thread here? I mean, this was shocking. Something I will never forget. She didn't want to tell me. She wanted to tell everyone in the universe that her husband had been absolutely, categorically destroyed by treatment. He was not doing well. He was not there anymore. This was personality annihilation. Right? This is something that happens. People may not talk about it, may not call it that. He did not complain about any of the symptoms because, don't get me wrong, she told me he did not exist anymore. He didn't care about anything. When I told him how great he was and how excited I was, his PSA was less than 0.03, he just shrugged. So what? You know, she was angry to a degree, but infinitely sad. This was devastating. And her words, no one told us this could happen. He was never consented about hormone therapy. We have a neurologist who's a little bit too free as people are. Any kind of disease that might benefit from hormone therapy, he gives it on the way out the door. He literally says something that can get this party started. And we'll thank the lady for it. This is going to shrink the tumor and all. So in this case, and this is not representative, but this is something everyone has to think hard about the possibility. Everyone here, you can Google this. There's a radio show that you should listen to every Saturday. It's the greatest radio show in the world of great podcasts. This American Life, ASTRO. Just write that down. It's an hour-long show that will change your life. There's a man in full account of what it was like to walk through the world with no testosterone. It's just a fantastic show every week. This one is exceptional. But what do we know about ADT? Well, we know it has tremendous advantages, right? Overall survival advantage with external beam. If you take external beam and add hormone therapy, you can probably add a year or two to life. It can shrink the prostate, it can shrink tumor. The disadvantages, though, are kind of minor. Hot flashes, weight gain, loss of libido, cognitive dysfunction, minor mental illness, loss of muscle mass, loss of motivation. Those are, I would say, tolerable. Then complications are rare, severe depression and suicide, right? The docs from Harvard emphasize that. Remember, this therapy has a suicide rate. How many therapies for cancer have a suicide rate associated with them? Personality change, what I have called personality annihilation, cardiovascular death early, proven, noted, cardiovascular death late, somewhat questionable, but I think evident. And dementia. First 4 years ago, they said dementia is a risk. Then they countered this. I'm sure the companies countered this quickly. Oh no, dementia is not a risk. And now last year they had a study with 35,000. It's a slight risk. It's a slight risk. But all I've done is I've made sure that anyone getting a hormone shot goes home, breathes about it, and is incented for it. Because if you're going to change someone's life this much, put this much at risk, then they have to know, right? You're going to give up 2 years. It'll take a year and a half to recover, and 30% will never recover. If they know that, how many men decide they don't want to take it? Even if they can live 2 years longer, they say, well, you're going to ruin 2 years right now. You don't, the logic is inescapable for some. 40% in my current practice, 40% of them say, nada, I'm not doing it. Not quality of life. I'm hitting the gym. I got a sex life, Y and Z. So again, you have to have your triangle straight to go that far. You have to know your bottom line. You can't just nod your head when someone says, oh, you need hormones to improve your survival. Quality of life study in England, I quoted this in the paper, it said that the average quality of life for men getting curative treatment for prostate cancer is the same for men dying of prostate cancer. Commonality is they're both getting hormone therapy that can be absolutely devastating. So for my practice, after that one man, I said, I am not going to give any man over 75 hormone therapy because he doesn't have enough years left to realize the advantage, and I could ruin his life completely right now. So this is the state of the art, though. There's no question. This is the 10 years. If you have external beam, you add ADT to it, you get a big advantage. There's no question about that. If you take combination in ADT plus beam or high dose rate plus beam, there's probably an advantage, but you usually would take, say, 6 months instead of 2 years or 18 months. So it's much shorter. Seeds plus beam allow you to limit that. Interesting thing is, though, if you go out 15 years, the failure rate is much higher. They have a late failure rate, so they get a lot of hormone therapy early, and they need a lot of hormone therapy late. And for a good number of men, that hormone therapy is kind of the end of their life as a man and their life as a whole being. So it's a huge, huge price to pay. That's why I'm advocating for at least consciously making the decision. That said, ADT in reality is what I call a 20-20 proposition. 20% of men have devastating side effects. They don't even want to end, they'll quit early. 20% of men have, they're not bothered at all. So who are you? Which are you? And how do you decide? When do you bail? You are with that 20% going to be life altered. Well, I don't think you puff it out and grit it out for a year or two, feeling utterly terrible. I think you get out of it. So combination, I do combination because you get a plateau in the curve, a flattening curve, and you can limit ADT. And if some of these guys say, I'm not taking it, I don't see doing that combination. We have no proof at all that ADT, if you do this combination, no proof in the ultimate sense of randomized trial combination changes outcome. Case 2, 56-year-old marathon runner with favorable intermediate risk, very smart guy, teacher, science teacher. He's got the kind of cancer. He came in and said, I either want seeds or I want to watch and wait. So he can watch and wait. He's sort of on the outer limits of that, but at 56, boy, is that ever hard to get someone to watch and wait. But he did an MRI, and instead of having favorable intermediate risk, look what we found. big tumor growing out. That's the black. Unfortunately, if I try to show you, I'm going to mess up. But this is black. You can see it growing out the front and completely unsuspected, probably not biopsy. That's very high risk lesion. And so it goes right down near his sphincter. So his surgeon was really trying hard to sell surgery. Unnamed surgery does make sense. But when I showed the surgeon this picture, this is that brown object right here is the tumor sitting right on the sphincter. He said, boy, I don't think, his exact words are, I don't think I can get around that. Better not. But so what did we do? We gave him hormones that shrunk the tumor down. Yes, you heard me right. I gave him hormones. He wrote a fantastic blog about trying to jog 2 miles a day with hormones. But it was just enough to shrink it. And now, he wrote the full course, 1.5 years out, where he regained his sexual function. He needed it to get that tumor back inside the gland. He had LDR plus very good outcome. But I can't imagine this guy having effective treatment without an MRI, having that really bad lesion hiding there. He was not favorable. He was high risk. Case 3, 54 years with high risk cancer. PSA is 7.4, Gleason high. This is just classic high risk. And again, MRI, to show, it shows a tumor sticking out the side of the gland. You can see it kind of plain as day. In contrast, you can really see it's outside the gland. So that can't be cured with surgery. I told him about combination. I told him because it's outside the gland, he'll need a brief stint of hormones. He saw another colleague who just trashed combination, said you're going to have terrible toxicity, you shouldn't do that. He got so disgruntled with these conflicting radiation procedures or recommendations. You can see local surgeons who were more than happy to tell a 54-year-old got bad cancer, you need surgery. And I told him, you outside the gland, you need radiation. After you get surgery, if you want to, you need 7 weeks of radiation after. But here's the consolation. You have a 2-centimeter sphincter. So he was a guy very worried about it. I mean, he looked like a random person. His wife were beautiful people, literally. They hit the gym. They look like you would see them on a magazine. They don't have a deck. They have a brand. I picture, if you can picture some fancy drink, they're sitting out there. They're wonderful, wonderful couple. I said, you don't have to worry about incontinence because your sphincter is long. Well, lo and behold, he goes to surgery and he signed on for a protocol where they said, we're going to do margin checking. So what that means is in the middle of the surgery, they're going to take the prostate out, and then if they see that they didn't get it all, they'll take a little more out. And he came back after his surgery. He said, Dr. McLaughlin, you told me I would not have urinary leakage. I am currently leaking full-time, 24/7. I need a penile clamp to stop my urine. This is like a 1980s level of incontinence, like diaper incontinence. So what happened? Well, I couldn't believe it when I got his MRI to plan for his treatment. Look, this is the sphincter right here, this black band. It's gone. He has a little tiny residual that was obviously not sufficient to hold back the urine. So this was a kind of a sad one, I have to say. If they had just done the surgery, we did radiation after, he would not have had problems. It's a pretty astounding shift. So personality may play a role in these decisions, right? We have not begun to sort this out. That's why I want to sort it out. Surgery is, on a psychological level, the obvious better choice. If a surgeon tells you you're young, you've got to get it out. If you're serious about getting rid of this, don't listen to anyone else. Don't do anything. Now that is not a lie. Most surgeons say that actually, but it's not true either. It's not science. It's someone caught up in their own game. Case 4, this is an actuary, probably knows statistics better than me, at an intermediate risk. We sent his pathology to God, otherwise known as Jonathan Epstein, Johns Hopkins. He said, this is Not a 7, it's a 6. I was ecstatic. A year later, though, after all the blood and everything was gone, he had another MRI, and there was an area, and this time it was a 3+4 treatment. I referred him for surgery. I have to tell you, whenever I refer someone as a radiation oncologist for surgery, there's usually like an incredulous look from someone. I can still remember one a year and a half ago, this one guy's wife said, "I don't believe my ears. You're a radiation oncologist and you're sending me for surgery." Well, you know, there are certain circumstances. If you're 46 years old and you're going to live 50 years and you have surgical curable disease, to me it makes sense to have surgery because you avoid radiation, you avoid the long-term 20-year effects of possible tumor from radiation. So in my mind, if you just keep in this advocacy position, you can actually make very good decisions, really help people to the best decision. He had surgery, he did great. He had good nerves, he had good sphincter, he's functional, he'll do great. But I don't know what I would have said if his sphincter was short, or he, like, you know, he probably would have said, "Hey, you know, you've got to decide quality of matters." So the last one, just to be fair about hormones, this is a guy with hideous disease, 54 years old. If you listen to the musical, this is a guy that's on testosterone. He's 54. He looked 40. He had a 35-year-old girlfriend who was 25. They were just, talk about a beautiful couple. This was ridiculous. They had it going. He had this horrible, horrible tumor. Not only, look at this tumor. So here's the screen left. This is marked here. Not only was it outside the prostate, not only was it in the muscle next to the prostate, the later, it was growing all the way in to the pelvic muscles out the side here. Look at this. And we would never have known this on CT. In fact, I could show you on CT scan years ago. If he had CT, no one would have ever known it was there. This is impossible. I can't do Reiki and bail him out. If he said, "I don't want ADT, just go ahead and do your best," I cannot implant this and cure it. But watch what happened with hormone therapy. This is the same cut. Look at that whole thing just collapse down inside the prostate. You'd have a very hard time convincing me that hormone therapy doesn't work by just completely collapsing this tumor back. So on the left, there's the tumor, and this is the same. If you look at the bones, you're at the same level, right? This is before ADT, this is after. Astounding. And it got him in the game. We treated him. He had a year of hormones, covered. Happy to say that relationship worked out, and he did recover his sexual function to a degree. So process between surgeons and radiation oncologists has always been poison. There's sort of a medicine barker. You go to the surgeon, he says, "Whatever you do, don't do radiation. Surgery is something to go." Radiation oncologist says, "Whatever you do, don't do surgery. Radiation is the only way to go." That's the medicine barker. Truly disgusting, still prevalent, right? And it's shocking that someone can look someone straight in the eye and say, why would you? That was a perfectly rational approach. But Jim Monty and I used to talk about this a lot. And what happened many years ago is we had this neutral position where I can't tell you what to do. I don't want to be unfair. I don't want to be a medicine barker. You make up your own mind. And I can tell you, this drove patients crazy. What do you mean make up my own mind? I have no idea what to do. You got to tell me what to do. So that wasn't a good solution. What I think is the solution is advocacy. The urologist I'm working with now, it completely open mind and says, "Hey, this guy's young, he's actually active. His PSA is too high. I'm not going to cure him with surgery. We should do radiation." So no one pitching their own game. They know that on certain patients, I will send them back for surgery. So conclusion, cure and quality of life defines treatment success. Variations in personality, functional anatomy, tumor extension and dynamic anatomy, look at every patient and a completely unique, never before and ever again challenge. How can we deal with science in one? It is possible to quantify most of the variations. You just go through, juggle those balls, and see what you got. And a reasonable answer will present itself that will get you as close to curing quality of life as you can. Advocacy is the best multidisciplinary sense. That's all I'll say. Patient self-advocacy is very helpful. You can get the TriMap, you can get your MRI score, but I have to tell you, it is still a challenging for me with this information together. And so don't, as much as I said this is a workshop and you can do this, you really shouldn't do it on your own because you have to trust experts who actually use technology. So the process, that's my process. It works great. And now my last observation about N equals 1 is one poet said Columbus discovered physical America. Who's the guy to the right? Some of you may know. Walt Whitman, probably the greatest American poet, discovered spiritual America. What was his riff? Self-respect, individualism. None of us are the same. We're all quirky individuals. But this was not egoism. He was not an egotist. He did sing the song of himself, but he loved his fellow man. Rogers said, I never met a man I didn't like. I think Whitman said, I never met a man I didn't love. He was just enthralled with the variety, the quirkiness. That's the N equals 1. The great promise of America. It does not include racism. It cannot square N equals 1 with racism. So I'll end with that.